Yeah. It says it's preparing to go live.
Right, it does say it's live.
Okay, well, in that case, it is. It is.
So good evening, everyone, and welcome to the January meeting of the Health and Wellbeing Board. I hope everyone had an excellent break. I am drinking from a pint glass, but it is water because I am trying to model good behaviour and doing Try January. So I hope everyone has had a wonderful break. Obviously, it is a rather stressful time of year, I know, particularly for partners in the NHS, and probably more so this year than others. So we will try and keep this meeting brief and to the point. So if we take apologies for absence first, we have a number of apologies from lateness from Councillor Mason, from Kerry Stevens, and from Nehar Unadkat. I think we've also got apologies for absence from Councillor Nagpal, and a couple of partners have sent replacements. So for Chris Hilton, we've got Claire Dillon, and I think for Simon Crawford, we have Mark Titcombe. So welcome to Claire and Mark, and thanks for coming this evening. Other colleagues will arrive as their previous commitments finish. I think we also have John and Naomi to help present on the JSNA that we will come to shortly, the sexual health JSNA. But before we do that, I don't think there are any urgent matters. Does anyone have any declarations of interest? No, fantastic. There aren't any matters to be considered in private. So can we approve the minutes of the previous meeting unless there are any urgent corrections that haven't already been sent to Keith? Take that as a yes, then we can approve those, and Keith, I'll sign them when I'm next in the office.
Sure.
And which takes
Nehar's just arrived.
Fantastic. Well, we can move on to item 6, which is the Health Watch update from Dan.
Thank you, Chair. I hope this doesn't feel too much like a bombardment of numbers, and hopefully hopefully I can provide some context to the end of the year of what we're looking at. I think Q3's data probably showed the sharpest divide between perceptions around the quality of care and the access to that care. And unfortunately, it's going in the wrong direction. Overall, 67% were positive in terms of feedback around the healthcare services they received, 24% neutral, and 9% negative. Now that's the overall review. If we start to break it down in bits, you'll see what I'm talking about. So we'll start with GPs. Quality of treatment remains strong. Overall, we saw 74% positive, and that has been consistent across 2022. I think the lowest we dropped down to was 68% positive. So normally above 70%. And then staff attitudes. So this is a more detailed question, and we distinguish between administrative staff and healthcare staff. But overall, again, 72% positive, and that's actually been trending up over the last 2 quarters. No big declaration as to why, but just we're seeing those numbers push forward. Where we get to the less positives, getting through on telephone at your GP was 72% negative this quarter. And that's one of the strongest responses we've had for 2022. Appointment availability was 53% negative. Now it's hovered around 50 to 55% the entire year, so no dramatic change. What we are seeing, though, in the qualitative data is just a little more anger, a little more viscosity around difficulties seeing their GP. If we move on to hospital visits, this includes Ealing Hospital, the Urgent Care Center, and Moorfields. Overall, 66% positive, 25% neutral, and 8% negative. what I've noticed with the hospital numbers is sometimes we get a swing from quarter to quarter and then it averages out. So we'll see sometimes 75 to 77% positive, and then the next quarter it's around the 60s. But overall averages is low 70%. Again, let's start with the awesome positive numbers. Quality of treatment is 85% positive, and it's been in the 80s pretty much the entire point of 2022. So just fantastic news, and great to see that people are happy with their care. Staff attitudes, again, distinguished between administrative staff and healthcare staff, is at a whopping 90% positive. And that's one of the strongest numbers we've seen throughout 2022. And again, attitudes towards staff and customer services, if we want to just label it that way, has been trending upwards over the last 3 quarters. Again, where we see the negativity is appointment availability, 63% negative response, and waiting times, 58% negative. Again, these numbers aren't too dramatically different to what we saw across 2022, but again, it's the frustration more at the fact that it doesn't seem to be getting better, but that it seems to be getting more of a hassle or a chore are the kind of the words that we see thrown around. But you can emphasize the positives around the care and just acknowledge the difficulties that sometimes it's taking to get that care. That's from me, Chair. Happy to answer any questions if I can.
Great, thank you as ever. And having just scrolled past the bit I was going to refer to, I think that on the covering note, there's a really helpful kind of series of recommendations. I don't know if you wanted to talk through those and just kind of what, from your point of view, could help that partners could do to improve the experience.
I mean, it's always difficult to say what initially will help right away or what's kind of the small things at the corners that may improve services. The one thing that we saw in regards to the Q2 report that you have in front of you was that we got a lot of feedback from elderly patients about the time of their appointment. Normally, the main issue is free travel doesn't kick in until later, so appointments after 9:30, and that we thought that worthy of a mention because it was such a dramatic increase in those saying, yeah, no, I get an 8 o'clock or 8:30 appointment, and it's just not practical, and it's incredibly difficult. And considering that around 40% of those we talk to tend to be over 55, and I appreciate that it's not the age when we enter free travel, but just to acknowledge that that's a large portion of who we see and talk to. One thing that we can note as a positive is we are seeing improvements in how administrative staff is supporting patients. What seems to be the difficulty and the real challenge is around patient choice. And it seems as if patients are having less ways to engage with their GP. So they're being told that either they have to get repeat prescriptions online and they don't know how to access that, or that they have a video appointment rather than an in-person appointment. And that tends to be where a large concentration of the negativity comes from. I would just emphasize that while I appreciate the challenges and difficulties, if patients feel like they're being forced into a situation or being denied a way to engage with their GP or their hospital, then it's going to be a serious frustration and a highlighted negative.
Thanks. Any questions from board members? People are moving around as hands go up. Neha.
Hi, thank you. So it's not a question, but it's a sort of reflection. I mean, the whole system has been under immense pressure. So some of the flexibilities that normally we would ask for are limited at the moment in general practice, but there is still a lot of work happening to try and improve systems and processes. And this type of information is useful, but it's just one source of the overall information that we're receiving and practices are receiving, but it sort of needs to be seen in the context of everything else that's happening. And we took a paper to this last scrutiny meeting as well, but we didn't get through it all for general practice access in particular. But we didn't get through it all. But it just sort of stressed how difficult the situation is. So I think this report needs to be seen in the context of the wider, I think.
No, absolutely. I think we all recognise that at the moment some of those scores are very, very good considering the context, and that it's not necessarily the partners around this table who can affect some of that. It's things like, for instance, the government getting around and actually negotiating a pay deal, and providing additional resource where necessary. So not holding people's feet to the fire in terms of things they can do, but I think, as Neha says, let's recognise some of the wider context as well. That although we have a system, it's not a system that operates on its own. It operates within a wider healthcare economy and kind of context of national funding. Any other comments on the Health Watch update? Mark?
Well, thanks, Chair. Yeah. It was more of a comment than probably a question. So just really helpful as ever to see this data. And I think it is about sort of using this in triangulation with our other sources, both internally and externally, to try and complete the picture. So and helpful in terms of some of those trends that have been drawn out from this, particularly around the for us, certainly the some of the waits we know for appointments are too long and are not where we would want them. A little bit of that is a sort of post-pandemic hangover as we work through that backlog. I would say that that is more of the sort of routine cases rather than the urgent and cancer cases, which we are prioritising, as you would expect. But I think in terms of the quality of the care, it's obviously pleasing to hear that and to get that feedback as well. And it's useful for us to be able to feed that back to our staff as well in terms, in difficult times, to say, actually, there's some external data here which is really telling a positive story as well. So just want to sort of thank Health Watch in that respect, and we'll certainly use this to help put the pitch together at the hospital. Thank you.
Thanks. So if there's nothing else, Daniel, thank you very much as always, and we look forward to receiving the next update. I think we can then move on to the sexual health JSNA. So Jane Darroch is our senior public health specialist in this area, and I think you're going to take us through the JSNA.
Thank you. Yes, we're going to talk through some of the highlights of the JSNA and also some of the experiences over the past couple of years. And Dr. John McSorley is here from London North West Healthcare. I personally can't see if Dr. Hampton is here. Yeah, so both clinicians are here from London North West. So I'll have a short presentation, so I'll just try to share that. Which I'm not really able to. I don't know if you can see that.
Not yet, but these things do sometimes take a little while to.
Oh, okay. Right, I think something is there now, is it?
Not that I can see yet.
Okay, just 1 second.
No worries. It was working before we went live with the meeting, because I saw them on your screen.
It was, yeah, and it's not now.
If not, I don't know, Anna, if not, I don't know if Anna, you could share them for Jane if you've got a copy.
Hi, can you hear me, Councillor Becker?
Yes.
Hi, sorry, I've just had a problem. I've just joined on my phone.
We have the Zoom. You're sharing the Zoom window at the moment, so I can see myself talking on your screen, which is very disconcerting.
Yeah, I'm sorry. I can see you as well, so that's it's not the same as when we did our practice run. I can just try and talk through it.
If you click on that, perfect. If you could just pop it on presentation mode, then we'll be able to. We can see them at the moment. So if you,
oh, great. Okay, that's great. Okay, you just can't see me. So
yeah, if you can pop it on presentation mode, then we'll be able to see a bit more. That'd be perfect.
okay,
Brilliant.
so we're there. Sorry about that. So yeah, I'm going to talk about the Joint Strategic Needs Assessment, the key highlights of this document. It was quite a robust document using population health data, service level data, and qualitative interviews with stakeholders. And this was undertaken by a public health registrar who was with us, who unfortunately can't be here tonight, and she has moved on and is in the middle of doing her master's at the moment. So just to highlight some of the key data for 2020, as we are all aware, an incredibly unusual year, and this is the need is likely to be greater. However, just to highlight a couple of issues with sexually transmitted infections, that Ealing and London obviously have higher levels than the rest of the country. And in particular, syphilis and gonorrhea, this is an indicator of high sexual risk behaviours. So it's just important to highlight those more acute infections. Another issue to highlight is that Ealing, alongside the rest of London, is considered a high HIV prevalence area. And in particular of concern is really about late diagnosis, that obviously the quicker that people can get tested, the quicker that they can get treatment and have better health outcomes. And there's lots of activity going on with this through the London Fast Track Cities initiative, which has been implemented locally as well. And another area of concern really is HPV vaccinations in girls in schools. And this was a very unusual year, and we have heard from the NHS Commissioner from NHS England that this is a data blip. However, there is a trend where Ealing is below London and below England. So that's something that we would like to address. We understand there's some additional catch-ups through general practice, but obviously I think schools are best located for that. So as I said, we had some qualitative interviews with stakeholders, and stakeholders highlighted that this is an area which we do know there are vast health inequalities. There are different needs amongst different groups. So they are shown there, in particular, just to highlight young people. For Ealing, Black and African and Black Caribbean people, although the population numbers are quite small, the need is disproportionate. People with physical and learning disabilities, LGBTQ+ groups, and gay and bisexual men. So now we just wanted to speak really about some of the successes and challenges that we've had recently. As everyone is well aware about the COVID pandemic and hangover, as sexual health services were recovering from COVID and about to resume more normal activity, the incidence of Mpox, which was previously called monkeypox, now officially Mpox, occurred primarily at the beginning in London. And the reason why this is important is because sexual health services were diverted to the Mpox response in terms of testing and also vaccinations. However, this is also an illustration of good practice, because after the initial outbreak, that this is now becoming mainstream, because it is those groups who are at more high risk for sexual health that are being seen. So they are receiving wraparound care in terms of PrEP, STI and HIV testing. And I might pause there to ask Dr. McSorley if you want to come in to talk about the mpox impact.
Yes, absolutely. I mean, I think, thank you, Jane. You've encapsulated it pretty well. We thought we were emerging from the COVID response to get going on various sexual health backlogs, and Northwest London, or Northwest Thames rather, unsurprisingly was both the epicenter of the monkeypox experience, and the first couple of months of that had a significantly deleterious impact on our ability to deliver across the rest of our ordinary usual activity. I would say, however, that LNWH sort of put a firewall around most of our STI activity and attempted to preserve the contraception and SRH capacity as much as possible. And the trust response to support the local sexual health services was such that we were able to minimize that as much as possible. So I'd say that although for London services, it was up to 50% capacity was disrupted, it was probably closer to 20-25% in our area. We also mobilized the vaccination response to address sort of other simultaneous needs. So you're quite right that individuals who were adversely affected and at highest risk of monkeypox simultaneously had highest risk of acquisition of other STIs, HIV diagnosis, and were high priority for PrEP. So our local trust response was to, in fact, embed all these responses into a one-stop shop service model, which is something that some of the rest of the country is attempting to roll out as well. So we've used the challenge of monkeypox to supercharge the Ealing and Brent and Harrow responses to simultaneous vaccination and STI testing and PrEP need in the same population. And we are very grateful for our local authorities' support and the rest of the system support, because it truly was sort of a multi-agency response across London. Thank you.
Thank you, John. And just to say a huge thank you to London Northwest Sexual and Reproductive Health Services, because service has continued throughout all these outbreaks and challenges. That is, really fantastic and really quick adaptation, and also integration with the London e-service for less complex needs for home testing. So that is fantastic that we had that in place, and that was it, we were able to enact that. So it really has led to a bit of a rapid service redesign. And also to say that with London, it is an HIV Fast Track Cities initiative, that there is also HIV testing opt-out in A&E. And why this is really important is it's reaching those groups that don't necessarily see themselves at risk or would necessarily access sexual services. So it is great that is happening, and also the Specialist Sexual Health Service has been supporting staff with that, and pathways into HIV and STI testing. So that's really, really good. Another area of concern for Ealing is that we have very high abortion rates, 6th highest in the country. And related to this, which we have been speaking about earlier on, about the pressures on primary care, is that LARC prescribing, which is a POF indicator, is very low for Ealing, with the 128th lowest. However, we have been speaking to GPs, and we are exploring other options about supporting the wider system with contraception. And I don't know now if maybe Dr. Hampton can maybe talk about some of the contraception plans that we have.
Yes, thank you, Jen. I do apologise. My camera doesn't seem to like Zoom. It's quite happy with Teams, but it seems to have a bit of a phobia about Zoom. Yes, I mean, we obviously struggled somewhat during COVID, being a very small team, but we did keep going. And although we clocked up some quite extensive waiting lists for LARC procedures, we managed to clear those with some sterling work from the staff doing an awful lot of Saturday clinics, so that we could actually now get back to, we think we're providing, whilst it's a very different service from prior to the pandemic, actually a very good service, with all services available pretty much on demand. We very much embraced sticking with some telemedicine. There's an awful lot we can do without women needing to come to clinic, and much greater integration with the provision of contraception elsewhere, particularly working with the post-delivery contraception pilot across the sector, which is looking at making sure that women have contraception before they leave maternity units. And we've been particularly involved with training midwives and maternity staff to fit contraceptive implants. So we're very pleased with that, and that's picking up. At the start of the pandemic, we lifted the age cap for pharmacies providing emergency contraception. It had previously been free to women under 25, but now it's available to women up to the age of 55 when you no longer need contraception. And as a result, that has increased greatly access to emergency contraception. And obviously pharmacies are a very convenient place for women to get this. Yes, we have the challenge of low IUD and implant provision in primary care. However, the community service has very high rates of delivery. And we are certainly trying to, as Jane said, work on some plans to get the existing GPs who are part of the scheme to increase their activity. And there is some early evidence that several practices who hadn't filed claims for a couple of years actually were doing a little bit of work during the pandemic, and they're now claiming, but to try and encourage those who are doing small numbers of fittings to crank their numbers up a little. And it certainly does appear that that's the case for some practices. Unfortunately, in many practices, it's only one GP who provides the service. So if she retires or cuts down her hours, we have a little bit of a problem, in the same way that we have a problem within the service being very aged deliverers of care. There doesn't seem to be as much interest amongst either younger GPs or younger doctors in taking up the mantle, but we're working on that, and particularly by looking at other healthcare professionals who we could involve in the provision of care. And at the moment, we're looking at physician associates, as well as pharmacists taking on additional roles. And as Jane says, we have very much, we welcome the availability of some forms of contraception free online through SHL, in addition to their STI testing. We've got a lot of ideas, and our outreach work with young people is now doing a lot more face-to-face work in schools. It had gone largely online, but we're very much sort of working towards a hybrid approach in the future, so that people can access services in the way they would like to access them. But sort of watch this space. There'll be a few changes soon. Thank you.
Thank you. And just to say to the clinicians, obviously, as well as delivering service, their own core service, so there is this ongoing support to other services as a system-wide approach and that includes the current procurement of abortion services, the integration of STI testing and contraception into that service as part of the solution to these high abortion rates.
Yes, very much.
Yeah, thank you. And another thing, obviously there has been, communications has been great, campaigns and outreach. Just as a huge thank you to the councillors for all their support for World AIDS Day and HIV testing. This is really, really very much appreciated. And it is particularly to try to normalise testing behaviour amongst those groups that don't necessarily see themselves at risk. And moving forward, we would like to expand some of those campaigns, for example, for women's health. So yes, and as I mentioned before about the HPV vaccinations, we would like to work with our commissioning partners and how we can improve that. So some recommendations: we are already collaborating at a system-wide. There is fantastic examples of the London Sexual Health Programme, all the councils working together on commissioning specialist sexual health clinics, and the London Do It campaign. We were really keen to strengthen that in locally amongst a wider range of providers who do have a remit for sexual and reproductive health, because we're just mindful that for some issues, there's lots of pressures across the whole system, but it would be good if everyone kind of integrates sexual and reproductive health into service provision. We want to continue the support for the London HIV Fast Track Cities initiative. Part of that is about prevention, but also about support for our residents living with HIV. And just to highlight that we do commission, Ealing Council does commission a support service for people living with HIV. We have an extension of that contract, and we will be looking for procurement options going forward. But we're really keen to maintain the level of service that we've received on that, and building on national plans. And as I said before, we would be very keen moving forward to get service user views, but also the views of people who don't necessarily use sexual health services, to try to reach those that are more vulnerable and at risk. With a priority really is for this year is really to support service recovery across the wider system. So thank you. I'm happy to take any questions, and I'm sorry if I can't actually see anyone at the moment, but I'll
no worries.
try and get back. there we go.
Thank you, Jane, and thank you, John and Naomi, for your input as well. It's a fantastic piece of work, and it's much larger than the slides you just shared. I think in the agenda packs there's a lot more detail and a lot more work that went on behind the scenes. So did anyone have any questions? Or Anna, you've popped up. Did you want to say a few words as well?
Yeah, sorry about before. I was having massive IT issues. It doesn't like Zoom today for some reason. I just wanted to say a huge thank you to Jane and Varthney for the work on this, and all the partners, and especially to John and Naomi for leading this. I think as Jane said, it's a very it's an excellent service with an awful lot of personal commitment from the staff that I think we saw all the way through COVID, and very forward looking. So I think we're really lucky locally to have that support there. And yeah, just wanted to commend the work, and just as Jane was saying, see how we can integrate this a lot more in terms of lots of other services, lots of other support for our residents, so it's not just seeing one specialist service over there, really have it as kind of general public health issue. But yeah, thank you, Chair.
Thanks. I think it's worth noting that this is only for noting this evening, isn't it? So it feeds in, I think, to the work we'll be doing over the next few years with the health and wellbeing strategy as part of the evidence base. So just for context, which we probably should have said at the beginning, but that's why it's coming tonight. Any other questions then for Jane and the team? No. So I think I don't know, other than noting it and it obviously forming part of that evidence base for the health and wellbeing strategy, are there any next steps we need to be aware of? Sorry, Councillor Steed.
Hi, Councillor. I hope you can hear me. Okay, great. Yeah, thank you so much for that report. A lot of very interesting information. Would that report go to HAS now, Councillor Blacker? Or can it be sent to HAS? I mean, I don't believe it's on the agenda for HAS.
I don't think it is. It's because it's for it's Anna might be able to explain better, but it's more for as a kind of a supporting document for us to publish the health and wellbeing strategy, to say that we've considered the needs and we've kind of collated the data. And I don't know, Anna, if we are taking the health and wellbeing strategy to HAS.
Yeah, thanks, Councillor Steve. So I think this JSNA is coming because the board's got that overarching responsibility for JSNAs, and I think this is one of our chunkier ones. So it's really almost after the kind of intensive co-work to get into that routine that our big JSNAs come here for awareness, for sharing the learning, sharing the recommendations. I think in terms of sexual health, as and when we develop a strategy which is slightly contingent on national work, I think the strategy would be something we'd take to HAS for scrutiny rather than the JSNA itself. But I'm very happy that we just link when it's published. Health and wellbeing strategy, we haven't got on scrutiny actually at the moment, but I'm very happy to talk offline about that. Thank you.
Okay, thanks very much, Anna. And I guess actually I can just email my colleagues with a link to the report, which is there. So yeah, okay, fair enough. I take your point. Thanks for your time.
Great, thank you. So are we happy then to note that the JSNA, it's not one we need to make a formal decision on, but we have considered it. So thank you again to Jane and the wider team. Item 8 then is Kerry, so social care update, including preparation for the future CQC inspections. Kerry.
Thank you, Chair. Do colleagues want me to share the reports? I'm happy to talk to them if people are happy to look at them on their computer. I can share them. Should I talk to them?
I think talk to them, Kerry. So I think take the presentations as read because they've been circulated.
Yeah. Okay, thank you, Chair. So as we've mentioned before, the CQC framework for inspection of adult social care departments is relaunching. The relaunch was expected for April 2023. That's now been pushed back towards the end of 2023. So that gives us further headroom and space to develop services. In terms of the preparation work for the CQC programme, there's been a huge amount of activity within the council and also with partners and customers and people who use our services. The programme of engagement has focused around the extant CQC inspection framework, but as you can imagine, if that's been put off for another potential 12 months, that may change once again, and we've seen it change a number of times already. So just to give you the overview of what's been done, the council has completed a self-assessment which is included in the pack, and that's based around a number of headings which CQC will investigate when their inspection programme begins. So that has been completed. The council has completed engagement sessions with staff so that we can say, this is what organisationally where we think we're at. Does this align with your view of the organisation? And we're also engaging currently with partners and people who use services to see how that correlates. So it's all about confirming where we know our strengths are, but also being very clear about where there's areas of development and improvement within the services, within the framework, but also outside of the framework. So I think this is important that we look at this as a business as usual, improving and achieving the best outcomes for local people rather than just driving for a CQC tick in the box. The third stage, which we're about to move into in the first week of February, is that we are the first council in London and one of very few nationally who have engaged with the local government association to carry out a peer challenge process. So it's in effect a mock inspection carried out by local government association, including cabinet members from other boroughs in London, including directors of adult social care from other boroughs in London, who will come in and do a mock inspection of the organisation And we've asked them to be very clear about where they think our areas of development and growth should be. So there's these 3-4 areas of work which are ongoing. Because of the extension in terms of the CQC implementation program, that will now enable us to develop and have in place a clear business and work plan for implementing the changes and the development areas that are highlighted through the 3 or 4 areas of internal and external audit of the service. So it was always our hope that we wouldn't be inspected on the 1st of April in the first tranche of the CQC inspection programme, but we now know that it's going to give us at least 12 months, we think, to have a clear plan and framework for improving the services and the outcomes for people who live in Ealing, and a byproduct of that, we believe, will be a good inspection outcome for the council in terms of our adult social care services. Is that sufficient in terms of oversight, Chair? I can do more if that would be helpful.
I think that should be fine. I don't know if colleagues, partners have any questions or comments on that process. I think it's, you know, as Kerry said, we are the first in London to do this kind of self-reflection and seeking that challenge from the LGA. So it's brave, perhaps, but shows how confident we are in our ability to go through that process.
And just to add to that, Chair, if that's okay, is that as the first and what appears to be one of the more advanced councils in North West London, certainly, is that colleagues and partners in other boroughs are speaking to us about what are our frameworks and how are we developing.
Thanks. Councillor Steed, is that a legacy hand from the previous item?
Apologies, yes.
Fine, I shall go to Neha then.
Thank you. This is really helpful. Just wondering, Kerry, the council have had peer reviews in the past. Is it similar to that you're expecting this to happen, or just against a slightly different framework, however?
So, if that's okay to answer, Chair, the last peer review that we had, because there was, as you say, Neha, there was a peer review programme across London through the London ADAS group. We had one when I first arrived in Ealing, so that's probably 3.5 years ago, and that focused very much just on use of resources. I think this is going to be much more cross-cutting, looking at wider system issues within adult social care, how we work with partners, and I think the London ADAS peer review was much more a supportive friend, and we're asking the LGA to be a much more critical challenge and much more to reflect the CQC programme.
Thanks, Kerry. Any other questions or on that? No, Kerry, any other updates on social care that we need to give at this point?
I think just to say, Chair, that we would look to bring the updated work plan back through Health and Wellbeing Board probably late spring, early summer, and we could do that as a rolling programme of actions to share with the group.
Thanks. And I think to preempt Councillor Steed, I think we've already been to HASP with some of this, haven't we? To make sure we're getting kind of that scrutiny and challenge from other members as well. But I think important that we carry on doing that as well. Great, thank you. So should we move on to the kind of the broadly titled system partners winter update? But we felt that rather than having each different partner give an update, we kind of group them all together. And Neha, I think, has collated the updates from across the board. So Neha, how is winter going?
It's tough. It's it's actually not going to be me presenting. I'm going to share my screen, but VJ is going to do the first. Dr. VJ Taylor is going to do the first section, and then you'll have Mark from the hospital doing the second section. So I'll just share my screen.
Thanks, Neha, and good evening, everyone. As everyone is aware, the system across North West London and wider, particularly in terms of our health and social care partners, have been particularly stretched, and the unprecedented demand on services this winter has been much more than what we've ever experienced in the past. And as a result of this, as everyone is aware, there's been a lot of concerted and collaborative efforts to ensure that the health and social care partners across North West London worked collectively to deliver the services and the care for the population. And to do that, we have stepped up our gold meetings on a daily basis, so that the information sharing across the partners is comprehensive, and that individual health partners can support each other to ensure that the flow of patients through the system is as seamless as possible. From a primary care perspective, and the next slide describes what we've done in primary care, is that we have increased primary care capacity in North West London and in relation to Ealing by introducing and extending our access hubs over winter. As we described before in the Health and Wellbeing Board, we have our enhanced access hubs through our PCNs, and what we've done this winter is to bolster that with our extended access hubs on Saturday evenings, Sundays and bank holidays to support the UTC and the 111 redirections as well. And we've had to add some additional capacity on top of that by introducing more GP sessions across 2 of our hubs to support and facilitate the demand in same day, next day urgent care access across Ealing, and also the other boroughs have done the same as well. Our current utilization of the service has been 82%, which has been, really positive and encouraging. We will continue this additional capacity until the end of January, and we will be then review the situation to determine whether we need to maintain that extra capacity over February and March as well. The next slide, if now just put the next slide up. One of the reasons why there's been this increased demand, as everyone is aware, and there's been a lot of media press around this in terms of the surge of group A streptococcal infections in children across the UK, which unfortunately has led to several child deaths in the UK from invasive infection. As a result of this, quite rightly so, there has been increased concern and anxiety from parents when their child presents with fever and other symptoms of being generally unwell, and therefore they have sought medical attention earlier than they may have done previously, in terms of just to ensure that their child hasn't got a serious illness, and hence the level of activity through general practice and also our urgent treatment centres and 111 certainly has increased due to this. And there have been figures of 30% increased activity of children presenting across the system because of the Group A Streptococcus outbreak. That seems to have somewhat plateaued now, and the levels of children we are seeing is what we would expect for winter, particularly in relation to winter viral infections, which circulate this time of year, and so there is some level of stability returning back in the system in terms of how we manage children. What we also did because of this is that we set up some extra additional capacity across North West London, particularly in relation to paediatric hubs and respiratory hot clinics in some of our boroughs to help support our secondary care colleagues, particularly in relation to urgent treatment centres and A&E, to ensure that these children are assessed in a prompt capability and fashion, and then ensure that the right treatment is then put into place. This was also confounded by an issue around antibiotic supplies in our community pharmacies, and the issue was more around the logistics of getting the supplies to the community pharmacies rather than actually shortage of the antibiotics. And there was a particular shortage around oral suspension of antibiotics, which is primarily used in children. And then as a result of that, there had to be put some systems in place to allow pharmacies to use their ability to flex their capacity and capability of dispensing oral antibiotics for those children that are suitable for oral, to help support that supply issue. That has now improved and rectified, and I'm hearing on the ground that is not an issue anymore from our local community pharmacies. The next slide just describes some of the other areas of work and activity that happens, this winter and previous winters. I'm going to start off with flu particularly. So, as you know, there are increasing circulating influenza A in the community, and in fact, the levels of admissions for influenza A have increased in hospital admissions, as well as COVID as well, but particularly influenza A. So it's been really important that our population are protected and take up the influenza vaccination. And you can see on the slide here the uptake in the different age groups in the borough. I guess the first thing you note is that the uptake for the at-risk groups, which is 36%, is lower than what one would expect. And on the ground, we are seeing that despite the level of encouragement and reminders, there seemed to be some level of apprehension for the at-risk, some of the at-risk groups to come forward to have their influenza vaccination. But primary care as well as community pharmacies continue to deliver the flu program for this winter, and we will try and ensure that as many of the population are vaccinated as possible. And then we've had the COVID autumn booster program, which has been delivered primarily through our community pharmacy sites and also through CP House as well. And the figures here show the uptake. And I think what's more important, particularly in relation to this, is the housebounds who have been vaccinated. So 159 for Ealing, through our roving nursing program, as well as some of our community pharmacies have supported that, and also our 45 care homes have been visited, and we've had an uptake of 72% receiving the booster. And then we've had the polio booster, which also happened during the winter months with the polio campaign to booster children from the age of 1 up to 9 due to the incidence of polio in some of the sewage works in London. And the uptake has been variable, and so this was primarily a two-prong approach, using primary care to vaccinate the 1 to 4, and using our other sites, particularly CP House, and some of our community pharmacies also did undertake the 5 to 9 group. This program is still continuing until the end of. It did continue until the end of December, and we are now at the point where the active polio booster vaccination program is now curtailed. But obviously, it's still very important that every child works through the childhood immunization program, and we continue to ensure that is promoted at our GP surgeries to ensure that the uptake continues, because there was concerns, particularly for this winter, that we may potentially could have had a measles outbreak this winter as well, but that hasn't materialized, thankfully. But we do continue to ensure that our children are protected. The next slide. Yeah, so that's the end from me, and I'm going to hand over to Tim now.
But shall we pause there just in case there's any questions on kind of primary care before we move on to the widest kind of the London Northwest? So I don't know if anyone does have any specific questions for VJ at this point. Can't see any hands going up, so let's move on then to London Northwest.
Thank you, Chair. Yes, I'll just run through a quick sort of snapshot of where we are at Ealing, and we've tried to tailor this specifically to Ealing data and information, recognising that the slides were put together just before Christmas, but I'll just provide a bit of flavour there. I won't run through all of the headlines here, but I think the key point probably is around the communication and the engagement and working in partnership with our colleagues, really, in terms of preparation for winter and for the sort of current period. That's significantly helped in terms of achieving the sort of timely discharging and unblocking some of those delays. So whether it's the sort of regular daily huddles that we have with West London, with borough colleagues, with some of our community partners, some of the more sort of set piece discharge events, which I've picked out there, and indeed the Ealing Summit ahead of winter. They've all helped with the hospital flow, which is great. And we've also benefited from a sector-wide, so a North West London peer review process, whereby clinicians and therapists and others have across the 4 acute trusts have visited each other hospitals in advance of winter to look at each other's processes and see if there's any shared learning and best practice that can be picked up ahead of winter, which is good. I think the crucial point on this slide is probably the bottom bullet as well that I wanted to draw out, and it leads on to the next slide, which is that throughout this year we've been increasing our elective activities. We've come out of the pandemic, as I touched on earlier on. And indeed, as you can see, from October and November, we've been exceeding our plan, which is great. And we've continued that through December. So when I put this together, I hadn't got the December data, but we've got that now and we've continued that. And given the preparation and the beds that we've opened at Ealing, at the moment, we wouldn't anticipate having to reduce our elective or our outpatient throughout winter. We have sufficient capacity to cope at the moment, and that's very much what we're continuing to do, which is good news, and will see us begin to eat into some of those long waiters that we touched on earlier on. A couple of other points just to pick out on the next slide or two. We are seeing a very slight increase in attendances throughout the year, but as you can see, the admissions and the attendances are very much in line with what we were seeing pre-COVID. So when we go back to 2019, then there's not a huge amount of change. The way in which we're trying to manage that is very much through some of the within the hospital, is through some of those processes at the bottom there. So where we are able to take patients who've come into our emergency department, direct to our frailty team, put through our same-day emergency facilities, our ambulatory facilities, and of course assisted by some of what we've just heard from primary care and from working with our UTC colleagues, then we're able so far to sort of manage that demand within our emergency department. And that really leads me on to the very much a focus at the moment, which is the ambulance delays, which we're hearing a lot about. This data goes back a little bit. You can see here that we had a blip in October in our waits of an hour or more. But the key thing here is really about those processes that we've put in place to make sure that we can flow the patients through the hospital and out of the emergency department, and therefore stop those ambulance waits increasing to more than what we would want, more than 1 hour or more than 2 hours. We did have a further blip just in that week before Christmas, and I'll just touch on that in a moment in terms of some longer waits. But so far that has been, I think, pretty well managed in terms of at Ealing Hospital, and we're not seeing many waits in excess of 1 hour at Ealing. And then on the final slide, if we just jump on and take questions at the end. I've just touched on some of the additional work that we've put in place ahead of winter, particularly around making sure that we try and smooth the patient flow through the hospital and make sure that in our busy periods in our emergency department, particularly in the early evening, we've prepared and we can decompress that as much as possible and prevent those ambulance build-ups. We've opened at Ealing site, you can see we've opened 32 additional beds ahead of winter, again in preparation, and we're using the majority of those now to help manage the flow and to maintain our elective surgical capacity, and indeed using additional facilities at Clay Ponds and some of the block beds within the sector. Probably just worth picking out at the end there that the period of highest pressure that we've seen so far was very much that week before Christmas, when the sector moved to the escalation level 4. We moved with it, and then have since subsequently reverted to what we call Opal level 3 from the 23rd of December, and we haven't gone above that since, so we've been at 3 or below since. I'm very happy to take any questions or on either data or anything I've said, but hopefully that gives you a bit of a snapshot for where we are now, Chair.
Great, thanks, Mark. I think before I open to others, I think some sense of how the performance at Ealing compares to neighbouring sites. So obviously not all of our residents will all go to Ealing, some will kind of go outside, some not to Northwest London sites, but so a sense of how that compares would be might be really helpful for the board.
Yes, sure. I mean, I guess actually on the first slide, I guess I tried to give a feel for that, just in terms of the sort of that measure that we hear about a lot, which is the 4-hour A&E target or performance measure. So currently for November, just over 70%, so 7 out of 10 patients being seen within the 4 hours. And to give you a feel how that compares with the other 16 sort of acute sites within the sector, within the Northwest London sector, just above the middle of the pack, effectively for Ealing. I've relatively recently joined Ealing from West Middlesex Hospital in Hounslow, just over the border. So I'll sort of keep a close eye on how, and actually two quite similar performances in many ways there with our nearby colleagues. And we know that a couple of the hospitals, Northwick Park being one, but also North Middlesex would probably be another one that I pick out, which are particularly pressurised and are probably not achieving quite that level of performance, to give you a sense for that. I think also in terms of our, I mentioned the elective care, just to give a sense around that. We within the trust, and as I say at Ealing, but also across the trust, not having to cancel elective care is a good marker in terms of we know that isn't the case across the capital. So I think that's also a good indicator just in terms of the benchmarking that you asked for.
Thanks, Mark. Kerry.
Thank you, Chair. I think part of the difficulty in doing comparative activity is that colleagues may recall the delayed transfers of care framework that was in place previously. That data collection framework has ended. We're working with NHS colleagues, and the implementation, I think it's called Optica, isn't it, Mark, which is going to be the new system which will start providing performance data on a borough by borough basis. So it's quite challenging, Chair, in terms of providing evidence on performance by boroughs and council area. I think it's really positive to hear that we're so high performing compared to the rest of London, but there's obviously significant challenge within the system, and the council continues to work very closely with NHS partners to mitigate that.
Thanks. Any other questions then for Mark or indeed for VJ? If not, oh, sorry, Councillor Steed.
Thanks, Councillor. Thanks, Mark. Those 32 extra beds in Ealing, which I think you have on your report.
Yes, I can hear you. Yes.
Okay.
Yeah.
So what kind of occupancy have they? To what extent are you needing those 32 beds in Ealing, and what kind of occupancy rates are you having there?
Thank you. Yes, we are needing them, so we are using them, and what part of what that is enabling us to do is to make sure that we're not having to use any of our elective beds for our emergency patients. So as again, it's another part of that plan to continue to deliver the full elective programme and have that uninterfered by our emergency patients. How many of them are we using? Pretty much all of them at the moment. Councillor. So our bed occupancy is in the high 90s in terms of overall occupancy within the hospital. They are a number of them are on the 10th floor of the hospital in a ward area that we were not using and which we wouldn't expect to use during the periods of lesser activity during the summer. So we have planned to open those over the winter. We would plan to shut them again when we don't need them in the March or April timeframe.
Okay, Chair, can I come back on one point? Thanks for the response. I suppose that the next question follows on from that about staffing those extra beds.
Yes. So yeah. I mean, yes. Beds are clearly not open unless they're staffed. Absolutely. So and I did put a little bit in there in one of the bullets in terms of our planning around bringing in extra staff to make sure that those beds are safely staffed in accordance with our required ratios, etc. Now that's not something that we, as you know, we have a number of vacancies, and that's not something that we can just do easily. So it does require planning ahead. It does require some of our staff are obviously working a bank staff as well, so working additional time to make sure that we can safely staff those beds in accordance with the safe staffing ratios, and we're doing that.
Thanks. Mark. If there are no other questions, there was a question, I think, Neha, you were going to pick up from a member of the public. So we've been talking about some of those kind of targets, the 4-hour targets and so on. And there was a question from someone about the Hewitt review, essentially, and the suggestion that some of those national targets might be scrapped.
That's correct. So the question, and this related to a scanned clip from The Guardian on the 27th of December, as well, about a clip suggesting government to scrap NHS national targets, and we were asked whether we were aware of what was happening and how is the board and indeed the council responding to this. It was actually asked at our primary care executive group this morning as well, the same question, and I've responded there. But in essence, yes, it is the Hewitt review of the integrated care systems, and now we've moved to the new integrated care board and integrated care systems. Everybody had an opportunity to feedback, and that's organisations, individuals, councils, and anybody that was interested could submit evidence of what they believe is good practice and how things could change. This national call for evidence came to an end on the 9th of January. And when there is if you type in the Hewitt review call for evidence on Google, a whole page from the gov.uk website comes up where you can see the terms of reference of the review, etc. And everybody had the opportunity to submit, which closed, as I said, on the 9th of January. But that doesn't change the need to sometimes have some local flexibility to set performance measures based on the needs of the local population. And for example, the sexual health
report is one of the tools we would use to and other reports like that to set and understand the needs of the local population, and then establish systems and processes and measures that as a system that we are achieving those things. So although there may be a review of the national measures nationally, there will still be a need for local measures, and that will continue, I expect, but we'll wait for the review of the outcome of the review.
Thanks, Nehal. I'm sure no one will want to comment on the fact that the government has needed to commission a review of how ICSs can best succeed only kind of 6 months into their existence. Kind of suggest questions about how they were set up and introduced and thought about in the first place. But perhaps not a debate we want to have at 7:15 in the evening. We've got a quick update, I think, from Anna, and I don't know if Roxy's here, on the health and wellbeing strategy, which should be coming to our next meeting for approval. So Anna, if you want to take that and then run straight in, I think, to the work programme.
Great, thanks, Chair. Evening, everybody. So I think Kerry's going to kindly share some slides on my behalf, if that's all right, Kerry, but I'll start talking through anyway. So we've brought a series of updates and project overviews here over the last few months, because we're nearly at the kind of end stages of this. I'm just bringing something quite brief today, because we're at the stages, as you can imagine, where there's lots of tweaks around specific commitments, wording, etc. So I don't want to give you something that will change in the next few weeks, but really just wanted to give you a flavour of where we're at. Thank you, Kerry, for sharing. So just wanted to briefly mention on the structure. So we're talking about the forward being videos of lead members, myself, and some community voices in there. The kind of background in terms of the context for Ealing, especially in terms of inequalities, and that's something I'll just touch on really briefly today. And then two very helpful summaries of what's influenced the strategy and the kind of commitments that we're taking forward, and so you can really see where they've come from and that narrative. So that includes looking back at previous consultations and strategies, and also listening to the community voice and the themes coming out of that engagement there. And then the commitments will be the kind of the key part of the strategy, and then the next steps following that will be preparing to develop the annual action plans as part of this. So this is a 5-year strategy, obviously quite medium term. Things will change over that time. So I think some of the learning from the previous strategy was really to have those very specific SMART targets that are agreed by Health and Wellbeing Board members on an annual basis. Next couple of slides I'll show in a minute are just touching on a couple of those points in red there. They're very messy at the moment, and apologies, they're quite rough, but they just wanted to just give you a flavour, I suppose, of the kind of things that we're seeing both in the data on the inequalities, why that's so important, and also what the community is saying. So Kerry, we can move forward to these slides. So just wanted to share these with you in terms of the kind of inequalities we're seeing, and these are very Ealing specific. So for example, we're seeing about a quarter of jobs being paid below the London living wage in Ealing, about 11% of households experiencing fuel poverty, and then we've got specific inequalities within Ealing. So for example, levels of educational attainment, lower in our Black Caribbean pupils, so very much in a kind of underserved way through our education services. We've got a number of households overcrowded, and some of these inequality areas are increasing. So for example, percentage of families eligible for free school meals. Just on the next one, please, Kerry. And then just thinking really about how those inequalities feed into kind of health outcomes. So we do see, and you'll have heard this before at the board, quite high prevalence of both diabetes and obesity in Ealing, and obesity among children as well as adults. We do see big inequalities in that, as you'd expect. So, for example, 1 in 5 adults in the Bangladeshi populations in Ealing have diabetes. Prevalence of obesity is much greater in areas with the highest deprivation. So, for example, Northolt Primary Care Network is seeing kind of 2 to 3 times higher than South Central Ealing. And then a number, oh, sorry, Kerry, if you just go back one. Sorry, thank you. And then there's a number of other things we've talked about there. We've already talked about sexually transmitted infections and kind of inequalities in there. And you'll see inequalities in a lot of these other health outcomes on the right-hand side as well. So next one, apologies, this is a very busy slide at the moment and very colourful. We will tidy it up before the final publication, but just wanted to put it up here just to kind of show you the kind of themes coming out. So this is a combination of themes that we're hearing through previous consultations and strategies, so things like the local plan, Shaping Ealing, Women's Safety Survey. It's also the online survey we did for the strategy itself, and also a number of community conversations and focus groups. So there were themes very much about having local spaces and local resources where people could come together and really make those connections, and where there was a lot of emphasis put on the very, very localised community voluntary sector and faith sector as well, and how supportive that that felt to local people, and really how we could help that sector and those organisations to thrive. Housing came up as a general theme in terms of affordable housing, quality housing. And then there was a lot around, I suppose, the kind of equality, diversity, inclusion agenda and cultural competence in terms of having information and services that speak people's languages, understand different people's cultures, and the context they're living in, and also the kind of digital barriers in there. So in terms of service access as well, that was accounts as well as health services. And so there was also generally something around being heard. So even though there was definitely consultation fatigue mentioned at a lot of these events and things, people did want to be heard. They did want to understand how they'd influence something and be fed back to, and have that as an ongoing conversation. That came up really strongly. So next one, please, Kerry. So this is a very simple slide at the moment, you'll be pleased to hear. Just wanted to talk you through. So I think last time we came here, we may have been talking about 6 commitments. I think as we've talked it through with lots of people, we've got it down to 4. Just wanted to re-emphasize that these are still draft. So the commitments themselves, I'm hoping won't change too much at this stage, but the wording might change and the content within them. These with the coloured writing are almost our themes of commitments, so our kind of areas where we want to put most emphasis within the health and wellbeing strategy. And then with it below those, there'll be a number, 4, 5, 6 commitments within each one that will really show what we're committing to as health and wellbeing board members in terms of taking forward. And then as after this is published, we'll then start developing the action plan under each of those commitments for next year. So just wanted to give you a bit of a flavour under that first theme. Is very much around how we work hand in hand as equal partners with our communities. So some of that is building stronger collaboration, creating and sharing data much more clearly about inequalities and about lived experience. So really understanding the importance of that qualitative data, and also the kind of academic partnerships that can help us do that really well. Listening, as I was saying before, listening as a kind of continuous dialogue with our communities and sharing those insights across the partnership. And then a few more practical commitments around how we can actually help those community voluntary faith organisations to thrive, how we can empower them to do things more easily, and how we can join up between ourselves across the Health and Wellbeing Board partnership in terms of our relationships there. So some real practical things around training and building of skills. Under the second theme, which is almost a internal looking structural theme, I suppose, is really thinking about how we look at inequalities, how we look at equality, diversity, inclusion across the Health and Wellbeing Board partners, and how we actually have very much a shared proactive approach to that, rather than being a set of individual organisations all going off and doing their own thing. So we obviously have a lot of those structures in place already, in terms of how we share things together, how we share learning, and what our aims and principles are in that. But I think it's, we're on a journey with that, and I think we can carry on moving that forward. Some of that's about the Health and Wellbeing Board itself, in terms of cultural competence, how we hear the voices of our communities, and how we work together as a body, I suppose, and really take those responsibilities very seriously in terms of having that oversight of equalities and the inequalities agenda between our partnership, and really going back to some of the comments from our communities in terms of working together to work with our communities over time to get better at developing culturally competent communications and the engagement routes by which we talk to all of our communities and hear from them, and really do that together across our partnership. And then the third theme is about promoting community connections through the use of local spaces. So this is very much about our kind of physical resources within our borough, so both indoors and outdoors. So that might be, for example, about how we can optimise access to some of our community indoor spaces, for example, that we own between us all, but also how we can make our outdoor spaces healthier and really work with our communities when we are making changes and improving local areas, and really thinking about health and well-being of communities and inequalities as part of any changes being made to community spaces. So really having that kind of health and well-being impact assessment in mind as we're doing that sort of work with our communities. And then the last one is a newish one. I think last time you saw this, oh sorry, Kerry, just finishing off the slide before, we've been talking about housing a lot, and that's come up very clearly as a theme, but in terms of impact on our residents and impact on inequalities, we've broadened this last one out to include kind of high quality, healthy housing, work, education, income. So really, again, thinking about how we prioritise well-being and addressing inequalities and how we provide all of those and how we work with our communities on those, and including things around homelessness particularly. That came up very, very specifically through a lot of our consultation work, and really thinking about how we approach homelessness prevention in a system-wide way. So final slide, please, Kerry. Thank you. So just wanted to just outline again, so very much hoping to bring this to next Health and Wellbeing Boards, just going through those final steps and making sure that all of our partners are on board with this. Really important to get that buy-in as we go, otherwise we're not going to do very well with it. So really want to take that forward, and really want it to be owned by all Health and Wellbeing Board partners, and then really think about over the spring about developing the action plan for the first year. Part of that will be internal within our different organisations. Part of that will be very strongly about co-production with our communities, and then really thinking about how we kind of monitor and hold ourselves to account in this partnership. So I think that was all from me, Chair, but very happy to take questions.
Thanks. And I think that last point is a really, really important one. This isn't a council strategy. It's not an NHS strategy. It's a Health and Wellbeing Board strategy. And we are kind of a partnership of those different organisations. So we all need to own it and commit to its outcomes. And I think that point you make again, Anna, about the inequalities point, that we will not tackle those health inequalities unless we understand them and have that real shared commitment to understanding how different communities experience those health inequalities and what those might be across the borough and our different communities. So any questions on that? As Anna says, it is still a draft, and I know the team are working in a kind of frenzy to kind of put it all together over the next few weeks. So I imagine, Anna, there's still opportunity to feed in and through the various working groups and check where it's going. So if not, do you want to just very briefly run through the work plan? I know the next meeting is quite a busy one. I don't know if there's any shuffling around we can do, because I think there are a lot of items that we need to take.
Yeah, will do. Kerry, I don't know if you've got the Word doc I sent you in front. I've just tidied up the version that's in the end of the pack after having that conversation with colleagues about trying to not put everything in March. So at the moment, thanks, Kerry, I can see that's coming up. I'll talk through it. So at the moment, March health and wellbeing strategies on there is our kind of big item. We've also got 2 of our kind of adult commissioning items there. So a learning disability strategy and an integrated commissioning update, and then a couple of reports from Danielle and Healthwatch, I think, in terms of patient experience and care homes. Because we've moved things out, May is now very busy, so again we might need to have a look at some of these, but we have been talking in our council plan. We've got a new annual health of the borough report, so this is almost including a kind of mini snapshot JSNA of the needs and the outcomes in our borough, but also really looking across the council and its partners, including in terms of how across all the different departments we're improving health of the borough and taking that work forward. Simon's also bringing the strategy for the hospital trust, and then we've got a few smaller items in terms of deaths in the community. So you'll have seen some of the news recently about higher deaths in the last year, and review of that. Autism Action Plan, Better Care Fund update is a kind of statutory thing that we need to bring here. Again, the kind of Health Watch reports, and then a few items which may end up being shifted into July. But I think that's all, but I'm very happy if anybody's got anything to add or amend in there. Thank you.
Great, thanks, Anna. And the important thing to note about next month is because we will be adopting the health and wellbeing strategy, we will need to be in person, at least a quorum in order to do so, because, as I said, it's not the council's cabinet that adopts it, it's this group as a kind of a standalone statutory board. So if you can join us in person for the next meeting, please do. Otherwise, we may run into problems. So Keith will be able to update you in terms of room locations and things for that meeting, and do get in touch with Anna with any other items that need to be done, or indeed can be shifted from that very busy May meeting, if possible. I don't think there's any other business. So thank you all very much for coming. And I think that next meeting is then the 15th of March, and I look forward to seeing you there.